Getting started, no financial disclosure. We will go through 3 topics. First, I'll talk about when to go surgery in thyroid eye disease. Then we'll go through some pre-post photos with regard to the functional and cosmetic indications. We'll talk on the photos. Then lastly, we'll go which orbital decompression procedure we need, or it is our preferred choice in different patients. So getting started, when to go surgery, we need to know the natural course of the disease. We know when the disease is starting from the baseline of the normal, it goes up in terms of severity and activity. Then with or without medication, it's becoming stable, then going kind of settling down itself to end with the burnt out stage where it could be far from the baseline of the normal. Why do we need to do that? To have this curve, because at each site of this curve, we make different decisions. How can we understand where our patient is standing now? We need to document everything every time we see any patient with thyroid eye disease. That's why in our clinic, we have a form, as you see here, recording the thyroid gland disease situation, the other stigma of the thyroid or Graves, eye history, visual function, going to the proptosis, eyelid, ocular surface, ocular motility. We do everything here, and you see on some tape, on some places, we have put asterisks to the left side of that place to show this is the activity score. So when we are filling this form, we end up with this part. And I'm very happy to send anybody who is interested in this form for the documentation of thyroid eye disease. You need to just send me an email on the email address below this picture. So as I said, we go through this form to end up to this part. And what is this part? This is where we have 3 types of severity score for all of our patients, NASPECs, UGOGO, and Rondel, for different kind of research projects as well as management of the patient. And then we need to have the clinical activity score, what the score on the first visit and on follow-up is. Then at the end, we need to know where our patient is standing. Is the patient active? Is he or she in inactive state with medication, I mean immunosuppression, or without medication? And if he or she is in the stage of burnt out. This is what we look for, and I always urge people to have any kind of documentation they think they can do it easily. So documentation is the first thing to go through. Going back, if we know this curve and if we know our patient where in the curve is the patient, then we have a window of opportunity here. Why this is important? Because we can start breaking this curve down by the means of medical treatment for the patient ending up closer to the normal base. This is for medical treatment. How about surgery? Surgery is divided into 2 sections. Either we are going to do functional surgery for optic neuropathy, keratopathy, intraocular pressure, or intractable diplopia. These are 4 main indications for functional surgeries, any procedure in thyroid eye disease. You can do that anytime from the beginning to the end of the thyroid eye disease course. As you see here, different kind of functional, very severe ones. These cases, you can take them to the OR and do whatever procedure from orbit, sometimes just eyelid, strabismus, everything to save their vision and to relieve the pressure they are under. How about aesthetic or cosmetic procedure? This is totally different issue. We need to have our patients in the burnt out stage. What is the definition of burnt out? To me, it is when the patient is having inactive thyroid eye disease without medication. Not the patient shouldn't be taking any immunosuppression for 6 to 9 months and having a euthyroid state, not continuously changing the medication. How do we know our patient is here? Back to the form. I need to tick this burnt out to proceed with cosmetic surgery. Otherwise, to me, in our clinic, it is contraindicated. Checking this out means we can go for cosmetic surgery. How do we proceed with cosmetic surgery? In our clinic, we go from orbit, then strabismus, then eyelid, sometimes combining retraction surgery as well as blepharoplasty together, sometimes separately. It depends on the severity of retraction and predictability of the results. But remember, why do we follow the order? Because of 4 reasons. One, we know thyroid procedures are unpredictable. You don't know where you will get the result, how much the result will be after each procedure. Sometimes one procedure like orbital decompression is correcting everything, and we don't need to proceed with others. And sometimes, or most of the times, on top of every other reason, I need a break. You see the patient for a long time, you go through orbit, send them, I'm not doing a strabismus, I'm sending it to my colleagues to do a strabismus, then come back for the eyelid W, and this is a break for me. And each session of surgery teaches me how to proceed with the further procedures. These are 4 reasons I still keep the order of surgery, in spite of doing some of our respected colleagues are mixing parts of these surgeries and performing those procedures all together. But remember, if we are going to do any surgery, especially cosmetically, there are 4 don'ts we should remember. Do not go early. This is what they are insisting. They are young, usually ladies, coming and insisting on cosmetic surgery. Why? Because they think if they do surgery, they will be back to normal, to where they were. Coming to the second point, as Samer nicely mentioned, do not promise back to the normal appearance. If they are showing you an old photo pre-TED, do not accept any surgery. They say, this is not what you achieved. We can improve it, but we cannot get you back to where you were. Do not forget the time interval between the procedure. Don't rush. If you are doing orbital decompression, don't go for a strabismus in 2 weeks' time. Wait, sometimes those early diplopia, early muscle problems might get improved or worse. And then at the end, remember, thyroid eye disease never sleeps. That is what we need to explain, because some patients 7 years later coming back with reactivation of thyroid eye disease and say, okay, doctor, I had a surgery. Why did I get again thyroid eye disease? I thought surgery is the end point for that. It should be mentioned on pre-op counseling. You might get again reactivation of thyroid eye disease. How about the second topic? About functional as cosmetic, what procedures to go with. For the functional, you see, when you have such a thing, optic neuropathy, lid retraction, strabismus, everything, we go through all these procedures, but at the end, most of these functional cases do not achieve a very good cosmetic result at the end. This should be mentioned prior to any surgery. Sometimes we have a worse eye. For example, in here on the left side, I was expecting this eye to have less correction and less improvement, but at the end, the left eye is better than the right side because of a little bit hypoglobus in here we have. And then these are the things we get mostly. That's why we cannot promise back to normal appearance. In here, he was lucky, I was lucky, we did all these 3 procedures of decompression, strabismus, lid retraction, and this is a year after the procedure. Hopefully, you know, he and me, we are happy with that result. But this is not true, because sometimes you don't need to go through all the procedures. Just 2 or 1 procedure will do the job. In here, orbital decompression and then eyelid retraction were performed for this patient. How about the cosmetic ones? In cosmetic surgery, they sometimes come with this. You see that eyelid retraction. This is the unilateral almost presentation. But when you go and start correcting this, the other side is getting appeared. That's why be prepared for bilateral procedure, even in unilateral cases. This is 1.5 years later, and this is 2.5 years later, having a tattoo over there, and the eyelid is settling down. This case is very interesting because we have started doing unilateral for some reasons. Decompression first, the right side we did, patient developed subarachnoid hemorrhage, actually developed the left side paresthesia, then basically she improved actually in the 4 months after the operation. And it was a trauma to us during the decompression that caused the hemorrhage. We should be aware of CSF rhinorrhea, hemorrhage. These are the complications. So 6 months later, 2 months after relieving, the right side is okay. So we decided on going to the left side. And fortunately, she ended up very good results. And this is the 2 years after follow-up of having decompression, but no strabismus, eyelid retraction, and blepharoplasty together. And this is the case, again, with all the procedures from here to this 9 months, he required 4 procedures. Sometimes we end up with a high TPS. This is one of the complications of lid retraction repair, but this is unavoidable. In some cases, we end up like this. And not only does the decompression and then eyelid retraction improve the primary gaze appearance, but it improves the lag in down gaze, as was described by Dr. Hashim. So going to the third topic, what type of decompression we need to go and which one is the preferred one? To answer this question, we need to have 3 sets of information. One, the available techniques. The second one, the complications we get out of each technique. And then the access we get from each type of procedure. Then I will give you our preferred one in 2 types of thyroid eye disease cases at the end. So what techniques do we have? It is either fat removal, will give you almost, this is literature review, almost 2 millimeters of decompression, or bone removal, medially up to 3 to 4, inframedial adding 2 to 3 to 4, but this is the best one for apical decompression. When it comes to DON, this is the target for decompression, firstly. Then we have a bone removal of the lateral, either external or internal, nowadays internal more. And third one is combining this fat and bones from different walls. That's why what we know is we are moving from medial of the orbit, coming down inframedially, going to infratemporal here for fat removal, and going into the internal lateral wall. Medial wall is the best for DON. We know this is where we can decompress the optic nerve the best. How about the complications? Look at these 7 complications here. These are the literature review. The most common one, induced diplopia. It is happening more in medial and inframedial decompression rather than lateral and fat decompression. Hypoglobus, mostly inframedial and inferior. Nasal complications, mostly medial, almost always medial. Brain injury, medial. Globe injury, medial. So as we see, since the medial wall is the source of almost all of the serious complications, if possible, we need to avoid medial wall decompression. I will come to that, mixing all this information, how we can make a decision. Based on complication, don't go medial. How about the surgical access? If we go transfornical inferiorly, we can extend it to the caruncle up there, reach to the medial wall, having inframedial wall access through conjunctiva, and then we going most of the time internal lateral wall through the same incision with no skin incision, going and doing internal lateral wall. And if we are interested, we can go orbital fat decompression through the same incision, as well as having eyelid retractors, lower eyelid retractors over there, and lower eyelid fat pads. If you would like to, you can do blepharoplasty. You can reposit the fat at the same time by the same incision and do a retractor recession. So very versatile incision. Lateral skin for the lateral wall. Transnasal endoscopy goes just the medial wall, not the other walls, maybe a little bit of inframedial, but mostly medial one. And transantral, which is the old one. How about surgical access with no skin incision? This is interesting because nowadays people are looking for the methods with no skin and scar on the face. These three are providing us transconjunctival, transnasal, and transantral. So which one is giving us the best view panoramically to all the walls at the same time? It is the transconjunctival one to me. Because you can have medial wall, you can have everything by extending it from medially up to the carancule here and up to the lateral wall here. You can have access to every part of the orbit you would like to have access. That's why we have already published the endoscopy in the field of oculofacial plastic surgery. I urge my fellows, I urge myself to go through different territory of endoscopic approaches. We are already doing all of lacrimal procedure and cosmetic procedures with the endoscope. Why? I still am not convinced medial wall decompression through nose is better than transconjunctival, because when we are going through the nose, actually we have to hurt the nasal cavity. We have to remove the nasal mucosa to reach to the orbital cavity and bring the fat, invite the fat into the nose. We don't need to do that. If we go transconjunctival, we are just going through the ethmoid sinus opening that without entering. We have a barrier between the nose and the orbit. We don't need to open one dirty cavity to the orbital cavity from the nose. And panoramically, we can see much nice view of medial wall, whether it is because of the cosmetic or functional DON. However, having said that, we can have endoscopic decompression when we are looking for very posterior medial decompression because of the orbital apex crowding very much over there. Our preferred one, based on these three informations we are provided with, in any case of DON, we go transconjunctival orbitotomy, we go medial wall. If the proptosis is big enough and we need more wall, at the same time, same incision, no extra incision, no skin incision, we go internal lateral wall as well as infratemporal fat decompression. Very, very occasionally with huge proptosis of more than 28, sometimes 30, we need to remove inframedial wall as well. But nowadays we are not touching the inferior wall. But no DON, based on again three informations of complication, access, as well as the incision, we still go transconjunctival orbitotomy, but now medial is our second choice if the proptosis is very significant. We cosmetically prefer first to go infratemporal fat decompression like pectomy, as well as adding internal lateral wall. Sometimes we go to the medial wall as well. That's why balanced decompression, as Samer mentioned, is a choice for actually being performed for the cases with huge proptosis. Sometimes with just lateral, internal, and lipectomy, you can get 4 millimeter, sometimes 5 millimeter of proptosis reduction with no problem. To take home, preoperatively, consider what I said on the red slide. Don't go early. The aim is improvement and not normalization of the appearance. And remember, thyroid eye disease never slips. Timing of the procedures, For the functional, at any time you can go and do the procedures. Whereas for cosmetic cases, we need to wait for burnt out. And this is the definition making patient and doctors crazy. Because nobody on either side can wait. That is the problem. And most of these cases I see in my clinic, they have already had their part of these cosmetic surgeries because they had insisted and the doctor had accepted and had performed. Now we are dealing with the complications. Order, in spite of some new, and Mahmoud, I think we'll talk about mixing all together, but I still stick to this plan of orbit, strabismus, and then eyelid procedures. Preferred orbital decompression, access to me is transconjunctival inferior fornix. And the choice of decompression depends on if we have a DON or no DON and the amount of proptosis. But preferably, we go for DON with medial and then the rest, but no DON, we keep the medial as a second procedure, not the first one. Thank you very much for